Good afternoon, everybody, and welcome to Boltbird and Kemp's webinar series, Growing with a Spinal Cord Injury. Before we get started, please kindly note that this session is being recorded. Your cameras and mics have been turned off. This is the fourth session in our webinar series, with our focus today being on medical considerations in children with spinal cord injury. We are very grateful to be joined by Dr. Jan Gawronski, who is a consultant in rehabilitation medicine at the London Spinal Cord Injury Centre. He focuses on rehabilitation for children with spinal cord injuries and is a member of the Rehabilitation Medicine Specialist Training Committee and the Children and Young Persons National Working Party. I am therefore very grateful to him for joining us today and sharing his knowledge and experience with us. Thank you for joining us. Over to you.
Good afternoon. Thank you, Rhiannon. And thanks to everybody for joining us. Last about minutes, 35 and 40 minutes, and then at the end we'll have some opportunity for discussion or questions. So if I cut out or anything, just jump in, Rhiannon. It's if there's internet problems. So I'll introduce myself. So I'm a consultant at the London Spinal Injury Centre, is one of the RNs for children and young people with spinal injury. So if I say we or us during the presentation, I'm referring to my colleagues, so the nurses, the nurse specialists, the rehab practitioners, the case managers, physios, OTs, school dietitian, and so on. So to give you some perspective, so children and young, so as my career's progressed, I spent more of my time doing rehabilitation for children and young people with spinal cord injury. How we really help people is by them being at Stanmore for inpatient multidisciplinary rehabilitation. This week we have 5 children and young people, 18 and under, are inpatients for rehabilitation. So those 5 have recently sustained a spinal cord injury of a certain level or a certain severity, and then got referred to us for rehabilitation. So we've got two 18-year-old lads, we've got a 15-year-old lad. So those 3 cases, they're all trauma cases, either falls or road traffic incidents. We've got 2 young ladies aged 10 and 11 who have an autoimmune inflammatory condition called transverse myelitis, who got referred to us from Stoke Mandeville, from the neurosciences department there, where they've had some medical treatment, and then they've come to Stanmore for their rehabilitation. So we get referrals from around London, the trauma centres, but the neurosciences centres and neurosurgical centres at St George's and Great Ormond Street, sometimes other hospitals. Later on this afternoon, we're doing a presentation of a case series of young people with transverse myelitis to the neurosciences group at Great Ormond Street. So we've got very close clinical links with them. So so I'm going to start the carry on a bit. So we're talking about injuries or a disease affecting the spinal cord, which is a bundle of nerves inside the vertebral column or backbone, and carries messages from your brain to your body and back up from your body to your brain. So this diagram on the left here, I'm assuming you can see the cursor that I'm moving. So this is the actual spinal cord within the spinal canal. This is this diagram is sideways on or sagittal view. Imagine you're looking at middle C1, that of the spinal cord. So we've got 8 spine, 5 in the lumbar or L spine, and then some sacral nerve roots here. So a couple of things maybe for people who either knew or you've got some experience, a couple of things to point out here in terms of the anatomy and how things are aligned. One point to make is that the neurological level of the spinal cord doesn't necessarily sit adjacent to the bony level of the vertebral column. So imagine there was an injury or fracture through T10 here. It's actually adjacent to the T12 level. Imagine there was an L1 fracture or injury here. That's more likely to affect actually one of the sacral nerve roots, or this is called the conus, as the spinal cord comes to an end here. Then as the spinal cord ends around L1 or L2, a bundle of nerves travels down, that's called the caudal equina. So that travels down through the lumbar spine into the sacrum and carries nerves into the pelvis for bladder function, for bowel, for sexual function as well. So sometimes there's a discussion about, is cauda equina a type of spinal cord injury? So at Stanmore, we consider it to be a type of spinal cord injury because it has the full house really of spinal cord injury consequences. So motor weakness, sensory impairment, often very severe pelvic dysfunction, so bladder, bowel, sexual dysfunction, neuropathic pain. The only main difference is patients with cauda equina generally don't get muscle spasticity. So spinal cord, let's think about it sort of conceptually. So this is a picture of the M25. So the reason for showing this is that it's a two-way thing. There's traffic going one way, and then there's traffic coming the other way. So that could sort of functionally represent the spinal cord. So normally these things are just happening automatically. So got some motor messages controlling the movement for in our limbs, in our trunk, our respiratory muscles. Then different sensory modalities, so touch, pain and temperature, pain. And I'm going to talk about this a little bit later, the autonomic nervous system as well, that automatically, without us having to consciously do anything, regulates things like digestion, our bladder filling, our bladder emptying, bowel, cardiovascular system like heart rate, the caliber of blood vessels and so on. So there's broadly two types, or I guess two classifications of spinal cord injury. Has it been caused by trauma or has it been caused by non-trauma? In children and young people, it's predominantly non-trauma. Traumatic injuries are relatively uncommon, but when they do happen, so road traffic incidents, so that might be like a seatbelt injury across the chest or sort of thoracolumbar area, falls, sporting incidents, diving, physical assaults. Sometimes we go through phases where we get, for example, seem to have a run of young people who've been injured through knife attacks or through stabbing in London. In certain parts of the world, gunshot injuries are a very common cause of CYP, spinal cord injury. The majority of the cases we would get referred would be come into the non-traumatic category, so inflammation or autoimmune inflammatory conditions. So our two young ladies who are with us at the moment have this condition called transverse myelitis. Different infections, so in certain parts of the world, TB is very common. It's not uncommon in the UK actually, so we sometimes get referred patients with tuberculosis. Sometimes unusual or rare things like cavernomas or fistulas, so abnormal blood vessels that have bled. Sometimes young people have had surgery for kyphoscoliosis, and that's high-risk surgery and can be associated with spinal cord damage. And then tumours as well. So we work quite closely with Great Ormond Street, UCL, and the Marsden. So the type of tumour is partly depend on the age of the child. So primary CNS tumours like neuroblastoma, quite common in young children and toddlers. And then a whole range of CNS tumours, older like lymphoma that might have caused a spinal cord injury. So irrespective of the cause, the young person might present with a spinal cord injury. So it is going to explain why we consider it to be a multi-system disorder. And I think one of the defining features of spinal cord injury is that everything that can go wrong goes wrong. You've got a young person that can't move, they can't feel, they can't empty their bladder or their bowel, can't feel their skin normally, and high risk of getting skin problems, different sort of pain syndromes. For the high levels of injuries, can be respiratory impairment. And so lots to think about, and hence we've got a big team. So the skin, the bladder, sexual function, neuropathic pain, nutrition, bowel, respiratory, some of these things that you acquire like pain and spasticity, affects mobility, and there's this thing called autonomic dysreflexia. So we've got to think about sort of things in general. Everything will be affected, all of this young person's relationships, so their relationship with their GP, with their school, with their parents, with their siblings, thinking into the future, their ability to work. with their forever. Because thinking a little bit more about the levels of the spine. So I've got cervical spine, thoracic, lumbar, and sacral. The severity or level of debility are sort of C4, 5, 6. So 1 or 2 levels of injury can make a fundamental difference to the level of disability. So if you've got a C4 complete injury, in likelihood that person will just be able to maybe shrug their shoulders and will have lost sort of functional arm movement. C5, a single level down, can be quite functional for feeding, using the phone, so compensating adhesive screw or holding things, driving an electric. C6 maybe for transfers. There can be quite a big difference in stability and being able to sort of sit upright in a chair or having to use your arms to compensate for trunk weakness and your ability to transfer. Then in the lumbar levels, your ability to sort of stand or walk is dictated by how much strength and movement you have for hip and knee movements. You can walk pretty well without ankle and toe movements, but you're going to need some movement for your hips and your knees. So just a little bit more about the anatomy. So the spinal cord runs to my brain, or starts up here. So it starts at C1, comes out off your brain stem, runs through. Then in cross section, you have a disc, you have a vertebral body. The spinal cord runs here in the canal. There are spinal nerves. So the ones coming off the front are your motor nerves. Then we've got sensory nerves coming around the back. And I'm not going to get into too much anatomy, but some motor pathways at the front, your anterior motor horn here, some sensory here. So sometimes with an infection or a penetrating injury, only some of the cord is affected, not all of it in a uniform fashion. So the presentation can be determined by how the cord has been affected or the anatomy. So the relative loss of motor or sensory pathways. Another way I find it sometimes useful to think of things schematically in this diagram. So there's a couple. This is to show a couple of things here for a traumatic injury. So here's the cord surrounded by the vertebral column. There's lots of space for it, and there's CSF or spinal fluid surrounding it. Then in a traumatic injury, first thing that happens is blunt trauma or blunt force. The spinal cord is a very fragile structure. It doesn't like blunt trauma. And then there's this cascade here, they call it the secondary injury. So there's inevitably swelling. The swelling might be just sort of fluid, it can be blood, and the cord expands within a closed space. And then there's a lot going on here. But basically the cord, especially in the center, is prone to losing its oxygen supply. So there's ischemia. So there's 2 ways, I guess, of trying to proactively avoid these scenarios. The way to avoid the first injury is sort of accident prevention. Over time, there's been a number of research strategies trying to look at this secondary process, things like steroids, cooling, early surgical intervention. So it remains an active line of research, for example, at St. George's Hospital with Professor Papadopoulos, trying to increase the space around the injured spinal cord, trying to reduce this process of swelling within a confined space. In my opinion, there's no proven treatment yet to ameliorate or avoid this secondary injury. It remains a work in progress. So to run through some of the terms, if someone has weakness in all 4 limbs, we call it tetraplegia, not quadriplegia. If it's below the neck and it's just affecting but 2 limbs, the term is paraplegia. And then to think about this concept of complete versus incomplete, and that's really important for knowing what type of spinal cord injury you're dealing with, but also the chances of the prognosis, the chances of some spontaneous motor recovery. And to summarize, complete is a more severe type of injury, less chance of recovery. Incomplete is a very heterogeneous group of patients, and the pathway is very, very variable from between different individuals. So thinking about this sort of motorway model, they've got traffic traveling in 2 directions. So that might be normal. With an incomplete injury, some of the lanes are closed perhaps, but there might be 1 lane out of 3 open. With a complete injury, nothing going on, no messages going on. And that would be consistent, for example, in a very severe high energy traumatic road injury where the spinal cord has been very severely damaged. So we do this assessment. All the spinal cord injury centres in the world do this assessment, neurological assessment called the ASIA, and this stands for American Spinal Injuries Association. So that committee continues to evolve this assessment tool over time. So we check the right and the left, and we check strength in certain muscle groups in the arms and in the legs, and we check 2 sensory modalities, light touch and then pinprick discrimination. And by doing that, you're able to classify the level of the spinal cord injury and the severity of it. And that provides a lot of useful clinical information about perhaps bowel or bladder care. It provides something for the team to maybe have a vision in their mind of where your patient might get to with their rehabilitation. And it provides information on prognosis too. So there's an ASIA impairment scale. A is complete, which is the most severe type of spinal cord injury, through to E, which would be someone who has had a spinal cord injury, but then it has a normal ASIA chart. So they may have other consequences of their spinal cord injury. They might have hyperreflexia, they might have muscle spasticity, but they have a normal ASIA chart. B means you can feel but not move, and that's actually quite helpful if you're sitting on something sharp or hot and you can determine it, then that's helpful. C is you have weak muscle strength, insufficient usually to stand or walk. Grade D, sufficient or generally sufficient muscle strength to stand or walk, although D is a very, very wide group. Some patients with D at the good end, you wouldn't know they had a spinal cord injury. Some patients with a D remain essentially wheelchair dependent. So I'm just going to run through some of the key nursing and medical aspects, some of the things we're thinking about quite hard when our patients are with us and when we see them as outpatients. So I'm just, these in themselves, each one is quite a big topic, but I'm just going to give I guess a brief practical introduction about the key aspects. So one is a bladder. So if a young person has a a spinal cord injury, then in some way or shape, even if it's mild, they're going to have some neurogenic bladder dysfunction. So we have to think about bladder emptying, and our philosophy is twofold. One is complete emptying. So your young person, we need to check that they are emptying their bladder completely. They might do through this technique or intermittent self-catheterization. If they do not have good enough hand function, or there's other aspects, then maybe this suprapubic catheter. To start with, probably an indwelling urethral catheter that needs to be avoided as a medium to long-term option. The way to achieve low pressure filling is to start with medication, botulinum toxin, and sometimes surgical procedures, so cystoplasty to increase the size of the bladder and reduce the pressure within it. Another really big area is bowel dysfunction. So we're trying to achieve continence here and try to get your young person into a routine that works for them in relation to their school or their normal day and what else is going on at home. So we take it simple. So we need to think about their dietary intake, their fluid intake, some medications. Then we try and get them into a habit where they will empty the bowel once a day properly. So once a day, the distal end of the bowel is empty, and that might be with suppositories or digital removal of stool, or sometimes with time an irrigation system. And we have got a relatively small number of young people that have a surgical procedure like the ACE irrigation system, which sort of flushes water through the large bowel to sort of promote regular emptying. The transanal irrigation systems like Peristeen and Q4 have sort of come online really about the last 15 years, and to start with became established in the adult population, and then we saw them being used in teenagers, and as time has gone on, being used quite successfully in younger children. So worth considering, but try and keep things simple to start with. So get to a regular habit, good diet, and stimulate the bowel with suppositories or with a finger to start with. So key to that is and other aspects is eating well. So we have a dietitian as part of our team that sees our inpatients and outpatients, and I think the importance of a good balanced diet is heightened in young people with a spinal cord injury for lots of reasons, including they're not going to get no chance of achieving success with their bowel routine unless they are eating well. Next thing, I'm going to move on from sort of those bowel and bladder things to some musculoskeletal complications. So there's two things we think about, I guess, in young people a bit harder than we do in the adult population. And so one is kyphoscoliosis and one is hip position and sort of pelvic control. So if you get a young person, they are at significant risk of neuromuscular scoliosis. So they have weakness, but they also have asymmetry and high risk of developing kyphoscoliosis of the spine, which is a three-dimensional problem. So it's not just this sort of two-dimensional S-shaped problem. It's a rotation which then affects the shoulder height, affect the position of the ribs, the position of the pelvis, and therefore sitting. Sometimes you get the ribs coming down very close or onto the actual pelvis. It can be painful. So for this exercise, good position young people and their families is that they're constantly, as your young person grows, they're constantly juggling. They're growing out of their TLSO, growing out of their AFOs, growing out of their wheelchair, growing out of their sort of standing frame. So they inevitably comes with a lot of commitment to attend orthotics departments, hospital departments, and so on. So yeah, bespoke brace is likely to be necessary for your young person with developing scoliosis, or even before it started, to try and prevent it. Splints for the young people with tetraplegia, maybe hand splints. So a lot of time and resource goes on to orthoses. And this is not one of our patients' site, but not atypical. So on the left here, a picture of a young person who's developing kyphoscoliosis. And as I said, this is not a two-dimensional problem. It's a three-dimensional problem. And then the type of surgeries that can be offered in a specialist sort of surgical department is rods and screws in the back. There are other technologies. So in this individual, there's these sort of screws into the vertebral body lower down, and they are not free floating. They are attached by a band. So there are different technologies, but fundamentally the sort of screw and rod fixation is what's required to control such a long or progressive, got a sort of a double curve here. So the lower or mid thoracic going into the lumbar spine. So we Spinal specialize in deformity in children and young people, and lots of patients will be under our spinal cord injury clinic and also the spinal orthopedic clinic. Next thing to think about MSK wise is the hip. So for normal development of the hip requires good alignment, weight bearing, movement, exercise, activity. And if your young person misses out on that, the standing, the physical activity, then the hip isn't really anchored. There's no sort of stimulation or stimulation for the sort of pelvis and the head of the femur to sort of grow as a ball and socket joint. And so that's one of the factors, and that can be exacerbated by muscle spasticity, maybe your young person not adhering to your recommendations for prone lying, for standing, for stretching. So it's quite a big focus that the hips as part of your holistic assessment of the pelvis, of the lower limbs and the spine. So really important they have a proper fitting wheelchair that has this sort of balance between that it provides good postural support, high levels of mobility, ideally good level of independence, sort of allowing them to transfer it. So balancing all of those factors. And then we people who work in the young person sort of field quite big on different standing devices. So wheeled standing device, in my experience, works nicely in primary school, where the young person is probably in the same classroom every day or all day every day with a bit of movement. But when they move schools, move to secondary schools, and they're moving around, maybe that particular type of device, it sort of becomes redundant, and maybe they're in the wheelchair. But it's really helpful if you can establish a standing routine at school, incorporate it into daily routines at school or when young people get home. Next thing to mention is autonomic dysreflexia, and I introduce this topic with some reservations. The more I say don't worry about it, the more you'll think, why has he said that? Or why shouldn't I worry about it? So I acknowledge that a small number of children, young people do get it. They are at risk of it. We've seen it usually because the catheter's blocked or they're constipated. But I've seen more harm through an irrational fear of your young person getting autonomic dysreflexia than children actually getting it. And the irrational fear is often held by schools or by social workers who impose enormous restrictions on your child and the young person. They say they can't do this, they can't do that. Everyone must have specialist training. And I've had some quite robust discussions and disagreements with schools and social workers that their perspective is completely it's completely unreasonable and is actually harmful to the child. If you've got a young person who's walking around and can go to the toilet by themselves, they are not going to go autonomic because there's no mechanism for them to go autonomic. If they've had a spinal cord injury for 5 years and they've never gone autonomic, despite being constipated or having blocked catheters or breaking their leg, then they're not going to go autonomic. For that individual, the sort of passage as time has provided you the reassuring evidence. So, but it is a genuine risk, and we see it in a smaller number of young people, and it's almost always bowel and bladder related. So the blood pressure might rise 20 to 30 millimeters of mercury above normal. General symptoms are headache, stuffiness, sweating, flushed, blurred vision, and so chain catheter, flush the catheter, have a cystoscopy, take out the bladder stones. Next most common is constipation and other things, fissures, hemorrhoids, and then any painful injury, basically like a pressure ulcer, ingrowing toenail, epididymoitis. So yeah. So so I see autonomic dysreflexia as being on a spectrum of autonomic dysfunction. So as you're sitting, watching the screen, listening to this talk, your autonomic nervous system is on autopilot. If you get too hot, you'll cool yourself down. If you're getting too cold, you can stay warm by sending the blood to your core. And basically what happens in spinal cord injury, partly depending on the level, is that you have too much parasympathetic and not enough sympathetic. So imagine where I'm moving the cursor now. You've still got your vagus nerve, which is the main driver of parasympathetic activity. So you can still constrict your pupil, you still produce saliva, you can still constrict your bronchi, your heart rate will slow, digestive stimulation, your bladder's overactive, and you've lost relatively your sympathetic nervous system that sort of provides that homeostasis. So this is why if people say, why do I sweat funny, or why have my feet gone cold? It's because of this loss of sort of the yin and yang of the autonomic nervous system. And the extreme end of that is autonomic dysreflexia. So I've got a couple of slides here about call it psychological consequences of spinal cord injury, and just my perspective, I guess, and thinking about adjustments. So mostly the young people see that sometimes we do get referred newborns with birth injuries causing spinal cord injury, but mostly they'll have lived their life without a spinal cord injury, and then they acquire it through illness or an injury, and that's of course very psychologically distressing and confusing, and that sometimes compounds a pre-existing problem if they had a sort of social or emotional or learning problem. Of course, they can become properly depressed, and we in our team have psychiatrists, psychosocial team, sometimes use antidepressants, but I'd say maybe less often. So it's important, and as a team, that we address this. Sometimes maybe not with me, because I'm sort of the doctor dipping in and out, but with my colleagues who spend more time with the patient, sometimes able to explore these adjustment issues. And then parents, and the parenting situation is often not straightforward. There can be a sense of loss or grief. The parent might have been the driver, the parent might have been at the scene. In a medical illness, often in young people, there's a delay in diagnosis. The parents been taking their young person to see the GP, to see physio, to the hospital. With things like tumours in particular, we've seen often very delayed diagnosis, and that the parents' concerns have been dismissed over a period of time. And obviously, the whole range of sort of reactions to the diagnosis of a spinal cord injury, being in hospital. For the medical problems like lymphomas, other tumours, they can be in hospital for weeks and months, having very toxic treatment here. Over the longer time, the parent, the burden of being the caregiver, I'd say mostly falls on parents or families. They're with very high levels of injury or very disabled young people. We can apply for NHS care funding, but inevitably, there's a fundamental change in lifestyle, and that can lead to exhaustion. And people being quite worn out by, as I mentioned earlier, multiple hospital appointments, the day-to-day grind of getting up, the toileting, the bathing, getting off to school, and then the effect on siblings. The child is part of a family, often with siblings, and these are some slides we got that I got from our former colleague, Dr. Caroline McKenna, who's a child psychiatrist, that there can be acknowledged some positive emotional experiences through having a sibling with a spinal cord injury, about maturity, social competence, tolerance, advocacy, independence, and autonomy. But obviously, negative emotional experience as well. So they can be isolated, loneliness, bit left out, bit neglected to start with, while they're probably very ill or very severely injured. Sibling is in hospital, getting lots of attention, some more responsibility. Maybe embarrassment or guilt can be features. So just come back to a little bit about our spinal cord injury rehabilitation management and care. We big emphasis on education through the whole team, led by the nurse specialist. We like to meet with children and their parents to talk about what their diagnosis is and the prognosis, which is often very positive, actually. But one aspect of diagnosis and prognosis is uncertainty. We see a lot of young people who are improving whilst they're with us, and it's impossible to be certain the rate of their ongoing improvement and the eventual outcome. We have weekly goal planning. So the whole team, Tuesday afternoons, we meet every patient with their family and we set goals for the week. So SMART goals, what are you going to do this week? Are you going to go to hydrotherapy this week with the aim of eventually running or getting back to playing sports? We have a case conference where we will include social workers, sometimes other sort of community services that need to be involved in discharge planning. One of our young men, 15, it's taken ages. He's had to be rehoused for lots of reasons. So he's got new housing in Wandsworth. So lining up his new house, it's a brand new house in a new apartment block, plus NHS care, plus his equipment is run over a number of weeks. So this is some of our team here. So we have case managers with tissue viability for wound care, psychiatry, psychology, neuro-urology, respiratory, bowel management, a range of therapists. And one of the, I think it's a good thing at Spinal, when our young person hits 18, 19, they just seamlessly transition into our adult service. They're probably going to see the same, for example, neuro-urologists. There'll be a handover to our community liaison, same tissue viability if that's necessary, same therapy department as well. So what we're trying to do, a whole range of things. So to begin with, people say, it's all about the walking, I want to get up on my feet. But actually, with time, people realize there's many more aspects to it. So education, trying to avoid medical complications, improve resilience, emotional adaptation, getting back into the community, being more independent, thinking about safety. Primarily, it's our obligation to organise a safe discharge. I don't know what schools are like where you live in London. A lot of schools are still sort of Victorian estates and facilities, and that's less likely to be conducive for a wheelchair user. Our head teacher come to our goal planning, so she was there yesterday in our goal planning. So there's a school at Stanmore, and going back to school is a massive hook and focus for our rehabilitation. So we'll do a school visit, be in contact with the school, try and answer any questions they've had, and actually proactively say, this young person is coming back to school. This is an essential part of their rehabilitation. These are some things that you need to know and get ready for. So if your young person, so last, I think it's 2 Fridays ago, we had a secondary school young man. So he was discharged on a Friday and went back to school on the Monday. So our expectation is that they will go back to school the next day after discharge, and they will stay at school. So easier said than done, but it's a test of your rehabilitation. If they can get up in the morning, they can go to the toilet, they can get washed, they can get dressed, they've got transport to school. So it's a big and very important emphasis here. One thing I've noticed, we've had quite a cluster of young people transition from year 6 to year 7. I think we just noticed during 2022, 2023, 2024, and they often need maybe more advice or some thinking about that. Often a lot of parents will just sort this out and the school will sort it out. Sometimes it just needs a bit of, it's such a big change to can be a massive environment across split sites. And it's the sort of generic issues of going to secondary school, but amplified if you have a spinal cord injury and you're in a wheelchair. So I would say we would expect all of our young people to have an educational healthcare plan that they can take through for the duration of their education. So whilst we don't do it, we often, because it's the school that does it with the family, we're very happy to support and advocate for them. From 11, 12 through to this transition to our adult services, we instigate this Ready, Steady, Go transition program. So planning several years out. You're likely to be familiar with this. I think it was developed in Southampton, and in our outpatient clinics, the nurse specialist will sort of proactively address this. And it's just going through different stages as someone is a teenager, and we're trying to encourage them to be more autonomous and independent, to take control of their health. So children with spinal cord injury is kind of I would say, niche area of medicine and rehabilitation. When I say, I think I and my colleagues in our medical team, we look sort of internationally for some inspiration or ideas. And there's been a group in the United States who do research, they publicize, they speak at conferences. They are putting on a conference this December in Phoenix, Arizona. It's called the Steele Assembly. It's one of their former colleagues, Dr. Steele, an orthopedic surgeon in Philadelphia. And it only happens every 3 years. So we're hoping to present on some rehabilitation outcomes after transverse myelitis. So they wrote this textbook. So it's Dr. Vogel from Chicago and his colleagues. So there is a group there, and sort of spreading their influence, I think, of good spinal cord injury care in children and the young adults. So next thing, and one of the final things to mention, so we do work closely with all the spinal cord injury charities, so Aspire, Spinal Injuries Association. So I feel very positive about all of them, but I just flag up about the backup trust that you will know, and some of you be aware of this. So they definitely have a focus on spinal cord injury in children and young people. And the things that I have definitely observed and would provide positive feedback on are these ones. So they're courses, including outdoor activities, wheelchair skills, this sort of third dot education inclusion at school. So going to school, sort of breaking down that maybe fear or that uncertainty, broaching the subject. So providing some support and inclusion advice for teachers, the sort of managers at the school, the pupils at the school. And then on from there, mentoring, and then sort of 18 to 25 and volunteering as well. So I know the other charities do have different sort of lines as well, but back up, I think sort of I'll just flag those up because they're, I think, in line with some of the other things I've talked about. So that is the end of this presentation. Thank you.
Great, thank you very much. That was really insightful. I do have a couple of questions for you. You mentioned about children having use of kind of AFOs or KFOs, and I was just wondering about the link between those and kind of pressure sores. Do you see heightened pressure sores in children because of the use of those or not?
Yeah, for sure. Yeah. So that's common. Yes. So it's making these things is an art, not a science, and it's difficult to get it right, and sometimes needs adjustment. You're molding thermoplastic around a young person. They might be in a lying position when you cast it, but then they're sitting up when they wear it. So manufacturing it, even to start with, then say for a thoracic brace, if it's not applying some pressure of some sort, then it's achieving nothing. If it has to be applying pressure. And then that young person within 2 or 3 months will have changed shape, put on weight, and skin problems are common and a common reason why they are sort of discarded or they stop using. So it's it for sure. Yeah, there's no easy answer to that. And sometimes people do not live close to their orthotics department, and it's they're traveling for hours to have these things tweaked. So that is definitely a problem. Yeah, the skin and the pressure areas.
Okay. And another one, you mentioned about the importance of kind of diet and the dietitian. And on that, is there a link between and you talked about scoliosis, is there a link between kind of weight and scoliosis or not?
No, not directly. Maybe some people might have different view on that, but not directly. I would sort of consider them separately, probably. Yeah. I mean, obviously you can think of scenarios where someone gets into a bit of a downward spiral and everything's going when they're putting on weight. Kyphoscoliosis is getting worse, but I think of them as separate things. I would say we see very lean, very skinny kids get kyphoscoliosis. Yeah. Can you
Okay.
see me, by the way? I closed my presentation. You can.
Yeah, we can still see you. Yeah, perfect. And I suppose my final question before we let you go is, you talked about kind of atomic dysreflexia and the I suppose not putting too much pressure or not kind of putting too much on that. But is it the case that younger children, for example, maybe can't communicate or aren't aware of what that is, so it's reliance on the caregivers to be aware of those symptoms, because you may find that the child can't report it?
Yeah, well, that's certainly true, of course. But what I think happens more commonly is the child is just sick. They get a virus or a bug or D&V, and they get rushed to the emergency department saying they're at risk of autonomic dysreflexia, and people just lose. And I just think he's got D&V, or and people just so of course you're right that they can't. The 2-year-old's not going to say I've got autonomic dysreflexia, but they might have it, and they would get flushing. You've got to check blood pressure, got to check the catheter. Do a catheter. Empty their bladder. So all the things you said are correct, but unfortunately I think people will phone you up and say, I think our patient's going autonomic, and say, well, what's their blood pressure? And actually it's very low blood pressure because they're sick or they're septic. And you say, why don't you treat their infection and don't worry about AD?
Yeah, okay, I'm with you. Perfect. I think that brings to an end today's session. Thank you very much once again, Dr. Gawronski, for joining us. We take a short break in our webinar series now for the Easter break, and then we'll restart. I think it is on the shortly after Easter on the 17th of April. If you'd like to join those seminar series, then please contact the webinars sign up list. And thank you once again, everybody, and enjoy the rest of the day. Bye-bye.